Top Med Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Med Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Mitch Harrison here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
This next session is all about the emergency surgical patient, a special vulnerable group of patients who are at high risk of perioperative morbidity and mortality with little or no time to optimise. So can we make their patient journey less risky, more informed and better overall? Our first speaker is Professor Carol Peden. She is the Executive Director of the Centre for Health System Innovation and Professor of Anesthesiology at the Keck School of Medicine at the University of South California. She was named the Harvard School of Public Health Innovator of the Year 2016 for her work in improving outcomes for high-risk surgical patients. Carol is a fellow of the Institute for Healthcare Improvement and has helped design and lead quality and safety improvement programs all around the world. Before leaving the UK in 2015, she was an Associate Medical Director for Safety and Quality at a national level for NHS England, National Clinical Director in the Enhanced Recovery Programme for Emergency Surgery, and a board member of the NELA project. Please welcome Professor Carol Peden.
Thank you, Jill, and thank you to the committee for inviting me to Melbourne, which is one of my favourite cities in the world. And having lived in the US for 3 years, I can't tell you what a joy it is to be able to get a proper cup of tea without having to explain that I want hot tea with milk. So it's great to be in Melbourne. So this was quite a challenging title, I thought, Armed with Data to Improve Perioperative Outcomes, because there's a lot to talk about. So I'm going to race through a journey which I think and I hope you will think has a positive ending. And it's very appropriate that you're going to have a talk later in this session about ANS NELA. These are my disclosures, and I was a founder member of the Emergency Laparotomy Network, NELA. I was QI advisor to NELA, QI lead for the EPOC study, and I'm going to talk a little bit about EPOC, and QI advisor and a co-applicant for the Emergency Laparotomy Collaborative. Before I go on, I have to acknowledge all my friends and colleagues, some of whom are in the room, who've been absolutely central to all the data and work I'm going to show you, the NELA group, everybody that participated in NELA, EPOC, ELC, etc. And it's impossible to thank them all, but you'll see the work that's gone on. So I'm going to talk to you about an incredible journey. Sadly for you, because I know it's getting late in the afternoon, I'm not going to tell you a Disney story, but I promise you another photograph of a cute animal at the end of this talk. And I'm going to talk to you about a journey fraught with challenges, overcoming a lot of odds to make a difference to a very vulnerable group of patients. Now, my journey, and I think it's appropriate, this is 2018, started 10 years ago when I won a fellowship to go to the Institute for Healthcare Improvement in Boston. And my application was, how can we make a difference to emergency surgical patients? Because I, like many of you in the room, had stood in an operating theatre, and we'd operated on these very sick patients, and yet they didn't get the same resources that somebody who was the same age, perhaps having a colon cancer resected electively, would get. And I was really struck by why weren't we doing more for these patients. So that was my funding for the year, to go to the US and think about it. And to be honest, I didn't really know what to do, even after a year of education. But it struck me that the first place to start was to get the data, because this was a data-free zone. It might be hard to imagine now when there's so many papers and discussions on this topic, but there was very, very little out there in 2008 and virtually hardly any research studies. So, in the words of Deming, the improvement guru, in God we trust, all others bring data. And Ramani Munisinger and I published about this in the BJA, about you can have big data or you can have small data. But to a certain extent, it's just get started and show what the problem is. And that's what we did. This was the first paper we published with my colleagues in Bath. It was published in the European Journal. It's old data now, but the important thing was, what this did was stimulate conversation. So the European Journal, when they published this, wrote an editorial saying, we think this is a big issue, but we don't know, because this is only data from one hospital. And we could have been really terrible. But, they said, yes, this could be a problem. We need to have more data. So as I presented this, it led to conversations. One of them was with a chap called Dave Murray, who you probably know as another founder of and now chair of the National Emergency Laparotomy Audit. And he and three others, he and I, got together to found the Emergency Laparotomy Network. So we collected data from 35 UK hospitals, which was actually about a quarter. The number of patients was about a quarter of the NHS patients undergoing emergency laparotomy. And it confirmed what we'd seen in Bath. The mortality was really high, way higher than any other surgical procedures, or virtually any other surgical procedures, perhaps other than ruptured aneurysm, that we did. 15% mortality at 30 days. Fortunately, around about the same time, or shortly after, confirming that it wasn't just the UK that was an issue, the data came out from the National Surgical Quality Improvement Program in the US, showing very similar mortality on 37,500 patients. And then, slightly later in the BJA, the Danish cohort study showing an even higher mortality of 19%. So we now had a lot of evidence. Another paper, Simon's, this is actually, and when you read papers about emergency surgery, I'd stress that you actually look at whether the patients are operated on or not. The Simon's paper includes emergency general surgical admissions who were not operated on, as well as operated patients. But what you can see from Simon's paper, and we showed this in the network data, is a huge variation in outcome. Also in this paper, they showed that if you had more ICU beds and you had more CT scanners, your patients were going to do better. So we're beginning to see some system issues that we can tackle. But when you see this kind of variation, it means there's room for improvement. Now, how many of you have heard this? Hands up. Our patients are sicker. Our patients are older. Well, guess what? When you see this kind of data, your patients might be older and sicker, but somebody else has got similar older, sicker patients, but they're doing better or they're doing worse than you. So this shows that there's something we can do about it. When you see variation, you can improve. So another thing going back in the past, as well as when I was showing the data, and this struck me because when I was talking at the Emergency Laparotomy Collaborative wind-up last year, one of my friends from the UK who works in Guildford came up to me and said, I remember that patient you talked about. That's why I got interested in this. And this was a lady who I'll call Ruby. She was an 82-year-old lady. She lived independently, and she was looking forward to her granddaughter's wedding. She was admitted late at night and with a diverticular mass, and her surgery was delayed for 3 days because she wasn't deemed very urgent. Nobody thought to do a sepsis score. And she had bowel obstruction. And then she had her operation late at night, done by a registrar in surgery and a registrar in anesthesia. She didn't go back to an ICU or a PACU bed. She went back to the ward. And 3 or 4 days later, she got confused. We probably now know that that's probably delirium. She got pneumonia. She was slow to mobilize. She fell. And she never went home again. She went to a nursing home. So I think we could have done better for Ruby. But my point is, when you use the data and the patient's story that becomes very, very powerful. So imagine when you've got your ANS-NELA data and you're presenting and you're saying, 12% of patients die at 30 days. Yes, give the data and you may well be much better than that. But tell the patient stories. Tell what it really means to the individual, because the combination of those two things is very powerful. So I think all that data that I've just showed you created not just a burning platform in the UK, but a sort of an exploding platform that we had to do something about this. It wasn't enough to keep saying, well, these are old, sick, frail patients, they're going to die anyway. We'd shown that there was variation, there was room for improvement, we could do better. And I think the next part of the talk I'm going to show you, we can and we have made a difference, but the absolute core thing was having the data. I'd also like to talk about the fact that I think it wasn't just the data, it wasn't just the stories, it was the fact that we all, and I'm talking generally, surgeons, anaesthetists, nurses, theatre nurses, ICU staff, we all recognised that there was a problem here, that we were not doing a very good job for emergency surgery patients. We weren't prehabilitating them, which we couldn't, but we weren't really doing anything. We were just letting them to take their chances. And I think now, if you go to the UK, you will find that every hospital is talking about emergency laparotomy. Everybody's thinking about it. And the quote on the right by a US criminologist saying that major social movements fade away because they've become a permanent part of the landscape, I think is what's happening in the UK. And when I gave the Macintosh lecture 2 years ago at the Royal College in London, talking about the things we've done with emergency laparotomy, one of the feedback forms from a registrar in the audience said, "Why is she talking about this? We all know what to do for emergency laparotomy," which was kind of like, okay, we've got this, because if the registrars all think they know what to do, then we're really winning. It's part of the fabric. We were talking this morning, it's not just about death. Death is the tip of the iceberg. When we don't do the best job we can for these patients, they get complications, they linger, they don't go home to be independent, all those things. So we have to think about it, that it's not just the tip of the iceberg. And this is data from the fantastic Michigan Surgical Quality Collaborative. 80 to 90% of the mortality in this high-risk group of patients, but also nearly all the complications. Another paper from Zara Cooper at Harvard showing the kind of mortality, but also, the fact that many of these patients did not return home. And look at this, if you're over 85, your mortality at 90 days, and remember, or 180 days, was 50%. And remember, that's the data we now are thinking about, not just 30 days, but do you get to go home? Do you get to be independent? If for the 75 to 85-year-old group, it's still 30% mortality at 180 days. Now, I've studied public health, and this is one of the most famous public health papers of all time from Geoffrey Rose, who was a professor at the London School of Tropical Medicine. And this is talking about the high-risk strategy versus population strategy, and the fact that we shouldn't just fixate on the highest risk populations. We should try to move the curve for everybody to the left so that even the younger, fitter patients have a better outcome. And if we do that, then everybody benefits. And I think by standardizing care pathways, having triggers for certain aspects of care, we do that. And I think that we are already doing that for this group of patients. So at this point, I'd just like to celebrate how far we've come. Back when we published the network data, the mortality at 30 days was 14.9%. The NSKIP data showed about the same 14%. The first NELA patient report, published in 2015, was 11.8%. Last year, for the 2016 data, was 10.6% 30-day mortality on average. And I'm not allowed to tell you what this year's one shows, but you can tell from the image there that, it might be heading in the right direction. So how did we get this improvement? Was it just the data? I mean, I do believe there is a Hawthorne effect, that when we don't know how bad or how good we are, we don't know which way to go. But what else was it? And what else should you be thinking about as you embark on this journey in Australia and New Zealand? So I think there's alignment of factors, the macro factors. You cannot do this alone as a keen frontline clinician. Your ducks have to line up in a row. So politically, somebody has to be talking about emergency surgery outcomes. At a national level, the colleges and the hospital system executives have to be talking about this. The payers have to be talking about it. And then, as I say, the hospital level, if you don't get, we found in the EPOC study, which I'll show you in a minute, the teams that were more successful had support and enrolled early, the chief executives, the chief financial officers. So again, don't think you can do this on your own. You need support at all levels of the system. One of the things we had, which came out around all the time we were publishing all this data around 2011-12, were standards. Prior to that, believe it or not, certainly in the UK, there were no standards for emergency surgical patients. And both these documents came out in 2011. And in fact, we've just rewritten the higher risk surgical patient document, which I think should be coming out later this year. And this time, it's really mainly focused on emergency laparotomy as such a high-risk group. So after all this activity, the UK Quality Improvement Programme decided to fund the National Emergency Laparotomy Audit to enable improvement of quality of care for patients undergoing emergency laparotomy. So the first data collection started in December 2013. And that was on a background of increased focus and discussion about these patients. So I think changing surgical care in the UK has not just been about the data. The data is absolutely central, but the data helps create the discussion, which was amplified by setting standards, having conversations at all levels at multidisciplinary conferences, the creation of NELA, and the vision that we could do something better. In addition, what I'm going to talk about in the next few moments is two major studies, EPOC, which was evidence-based perioperative care for high-risk surgical patients, and the Emergency Laparotomy Collaborative. So how many of you have heard of EPOC? The results were presented at EPOM in London in summer. The results should have been published 2 years ago, but for some reason, despite the fact it was an NIHR-funded study, it was hard to get the data back. Rupert Pearce was the principal investigator. I was the quality improvement lead. And this was based on the fact that if we used quality improvement, could we improve outcomes for patients if they had a standardized pathway? And it was an evidence-based pathway. This is the pathway. Now, this was designed to take best practice. It was a systematic review by Ravi Mahajan, who came up with the pathway and these things. It's complicated. And Tim Stevens and I divided it up into pre-op, intra-op and post-op to try to make it easier. But my hint is I wouldn't necessarily start with such a complicated pathway. But if you think about it, this is actually what we get. We get sort of guidelines, protocols, and we're told to, go forth and multiply with the protocol and expect to deliver improvement in all these areas. So there were 37 components to this pathway. And basically we thought there was a hard core of the project, which was the pathway, but around that we were building this kind of network of social activism, engagement, getting hospitals to build a quality improvement team, which included a surgeon, an anesthesiologist, and an intensivist. We encouraged them to use their NELA data. We didn't give their NELA data to them, but we gave them the tools to analyze it and turn it into run charts using quality improvement cycles and also breaking up the pathway into more bite-sized chunks. And NELA was the foundation. But remember I said NELA started in December 13. This project started in March 2014. So the NELA data entry was very new to people. So in proper trial design, it was a stepped wedge cluster randomized control trial. The hospitals were randomized in geographical clusters, and we had ethnographic and economic analysis. And I would say to you, if you're going to do quality improvement studies, have ethnographers. These are kind of anthropologists in healthcare. And they go and look at why things work and why they don't work. And the data capture was via NELA. So at 90 hospitals, so it was more than half the NHS hospitals. It was a fixed 85-week intervention. But remember, this was a stepped wedge. So some hospitals only had 5 weeks to improve this pathway. And a few had the full 85 weeks. We got 27,000 patients, and it was powered for a mortality reduction at 90 days from 25 to 22%. And it was basically every patient that was eligible. So if you look, we did manage, in the short period of time, we did manage to improve some processes. Some things got better. But basically, I think as we heard in the last session, there's a dose-response curve, and I don't think we had enough dose for the response we were seeking. And people, this is very difficult to see, but basically people worked on things that were easy to do. And that was mainly looking at risk assessment, because you can do that as a single person or a small group. You can't, it's very hard to change things like time to the operating theatre. So a lot of sort of risk assessment, both at before surgery and after surgery. So this is in press in the Lancet. It's been accepted by the Lancet. A lot of discussion because the outcome was negative. There was no difference with this quality improvement approach. It was very quality improvement light touch. The teams only got 1 day, which was a setting the scene and a half day of quality improvement, plus a database, plus some support. But really we designed it to be a pragmatic intervention that was more like the real world. So how much report do you need? So we did improve processes, but overall we made no difference. But remember, it was powered to show a reduction from 25 to 22% mortality, which was based on the historical data. Overall, we had 16% mortality at 90 days. So, everybody got better, basically. So what did they do? Most people used run charts, so they put their data into charts, which showed how they were doing on a daily basis, and analysis and feedback of data was important. And they also broke up the pathway, so they into more bite-sized chunks. So one of the things that came out, and this is worth bearing in mind, and I know I've spoken to Ben about it with the ANS-NELA, was that, remember, NELA had only started a few months before this study. And most teams spent nearly all of their time working out how to collect the NELA data rather than trying to improve. So I think that's something to think about going forward. How do you minimize that data burden collection so that people can focus on making things better rather than just collecting the data? So I know in some of your hospitals going forward, the data is going to be pulled from the electronic medical record, which I would think is going to be great. However, I would caution you to make sure you still understand, go and look at the records, make sure that data is accurate, and really sort of get under the data. Because if you're just presented with something that's a printout from an electronic medical record, you may not engage with it so much. Also think about data that's already there. This is work I put in because it includes Australian data. This is hospital episode statistics. We used the Dr. Foster database, and we looked at a number of hospitals around the world. And if you look at this paper, I have to say Australia does really well. So congratulations, Australia. The UK does not do very well. But remember, when you're looking at international comparisons, you're not necessarily comparing apples with apples. The US tends to send a lot of their patients out quite quickly to skilled nursing facilities, so the patients may not actually die in hospital. But what we found there was that transfer in this group, this was Australian, UK and American hospitals, transfer was associated with a worst outcome. If the surgeon was on site and freed from other duties, that positively correlated with better outcomes. High volume units and low volume units did worse, and that might be because the high volume units got more transfers and they had the sicker patients. And look at the ICU beds. The more ICU beds you had, the better you did. The other data you've got here is the fantastic Australia-New Zealand surgical audit, which shows you the patients that are sick, that are dying, the emergencies, the older patients. And the most common issue is delays. So there again, you don't have to go and collect the data. You've got some data there already that you can start working on. Where are the delays in your system? What are you going to do about it? So the other project I was involved with before leaving the UK was the Emergency Laparotomy Collaborative. And I would like to emphasise the amount of discussion around these two projects I think have helped drive the improvement. Rupert Pearce was great with EPOC. It was an NIHR-funded study. People wanted to participate in it. Emergency Laparotomy Collaborative was 28 hospitals, and it was scaling up the EPOC project, which I'll explain in a moment. But if you look at the difference. This was more a bundled care approach, a smaller number of things we're going to work on, and this was not real life. Emergency Laparotomy Collaborative was a really well-funded quality improvement study. I think EPOC was more like real life, if you like, on a day-to-day basis. So we had very clear goals, timelines, defined metrics. Again, we used NELA data and a standardized pathway. The emergency, it was a scale-up of this study, which had early assessment, early antibiotics if signs of sepsis, early surgery, goal-directed fluid therapy, and ICU for everybody. 4 hospitals in the south of England. So if you like, it was a pilot study which we scaled up with the Emergency Laparotomy Collaborative. So it showed a significant reduction in risk-adjusted mortality published in the British Journal of Surgery in 2015. So in the collaborative, we had more focus on the elderly, the frail, early identification of sepsis. We took a sort of enhanced recovery approach, enhanced recovery light, if you like. We had a lot more time with the teams, a lot more quality improvement, a lot of focus on change management and leadership, how to lead a team that was going to make change happen. And again, it was a year later, so people were more familiar with collecting the NELA data and they could work more. But you can see how much more input. Remember, EPOC, the teams got a half day. With this, they had frequent meetings and coaching in between. And we gave them their data. We actually gave them data back that looked like these run charts so that you could see how you were doing. And we also used benchmarking, so you could see how you were doing to all the other 28 hospitals in the collaborative. And collaboratives are important because you can meet regularly and share your improvement or your failures, and I think that's an important point with these. So the results were that, and this is, we're submitting for publication now, nearly 6,000 patients had an emergency laparotomy. The mortality rate improved from 9.8% to 8.7%. The national data, the NELA data at the same time was 10.6%. The length of stay fell. Teams were happy. We built quality improvement knowledge, and we did improve process measures. And I know that there are people in the room, and the Western Australian audit, that might get down to 5% mortality at 30 days. And there were teams in this, including my old hospital in Bath, who got down to 5% mortality within this project. And people were happy. Get people together, get them sharing their data, drawing their graphs, celebrating it. And we talked this morning a bit about burnout. And this is a good way to get them focused on a project, sharing ideas and coming together. What else can we do? New directions for emergency general surgery. We just had a big discussion about frailty. This is what I'm working on now in the US and also collaborating with the Australian New Zealand College. And remember, when you're showing data, that very clear infographics like this with the money in the picture are very, very important. If you want to persuade those chief executives, those MPs to change, put this kind of data up there. This is the US, 164 billion in costs associated with delirium, the commonest post-operative complication in older patients. Get somebody to do this kind of infographic for you, very powerful. So you can go to the website, the Brain Health Initiative, and again, engage really senior people. We've engaged the American Association of Retired People, very powerful body in the US. And they're going to do the marketing and the flyers and the patient information. So again, we're aiming for a public health campaign and a social movement. Finally, don't forget the patient voice. If you haven't seen the New England Journal of Medicine Catalyst, the great articles, I was very privileged to be invited onto a round table to talk about how we hear and use the patient voice. And I think there are a number of things. We can use it in the design of care, as an input to care, and as measuring the outcomes of care. And it's actually surprisingly easy to get more patient input by just asking the more sort of consumer-faced questions like, how could we have done it better? Or the what matters to you question. So think about asking your patients those questions, even after their emergency surgery, and putting that into the design of your pathways. So I know there's lots of people working in this area, but the group at Harvard, Sarah Krupa's group, are particularly looking at this shared decision-making in emergency general surgery, the older patient, and not only hearing, but asking the patient for their opinion in an appropriate way. And I told you I'd finish with another cute dog slide. This is a patient we had at Bath who was dying following an emergency laparotomy. He'd had multiple repeated surgeries and he didn't want any more. What he wanted was to see his dog again. So we took him outside and his wife brought his dog in before he died. So that is, it's not necessarily, and I'm sure you all know that about operating. So to conclude, I think data is absolutely essential, but we need standards as well. We need quality improvement tools, and we need some ideas about how to do things differently or better. Otherwise, we're just improving something that doesn't work very well anyway. So in summary, we've seen, in the UK anyway, significant improvement in the last few years driven by data. And the data gives us areas for future work, such as frailty, the elderly, delirium, all those things. But don't forget the burden of data collection on your frontline staff. You need to also have really good means to feed back the data and to create action. Otherwise, it's not worth very much. And I think we've created a social movement. So going back to Ruby, we want to give reliable emergency general surgical care. So she may not survive. She may not have had a better outcome. But at least we know we did the best things reliably in an evidence-based way. Making it easier for us as the frontline teams to do the right thing for the right patient every time. Reliability means keeping promises to patients like Ruby. Thank you.
Top Med Talk.
Nick Majerison here. Thanks for downloading Top Med Talk. Top Med Talk is the broadcasting arm of EPOM, Evidence-Based Perioperative Medicine. EPOM has been advocating perioperative medicine for many years now, using the traditional conference circuit, where people have attended meetings from all over the world and heard some of the latest information. However, in the face of the COVID crisis, EPOM took a bold decision. We've transposed the entire conferencing experience into an online experience. Carbon-friendly conferencing. The latest information, the latest talks, the hottest experts, the most incisive analysis, and even the socialising. We've got it all covered as EPOM goes virtual. Hot on the heels of the huge success of EPOM 2020 live from London, we're now headed towards EPOM Chicago. Come aboard and be part of one of the most exciting developments in medicine since the stethoscope. EPOM Chicago. Get yourself to epom.org now and guarantee yourself a place at one of the most exciting conferences in the world.